didn't expect
Now I
that.
feel like I'm at school.
I know. Sorry. Okay, let's go. Okay. So let's do some red flags. All right, so you already knew poor feeding was a red flag, yeah?
Yes.
All right, thank you. Y'all still have to talk to me on here because I'll wait
Yes.
for you. Okay, cool. All right, failure to thrive, because if they have a heart defect, they're not going to eat well. If they're not eating well, they're going to be failure to thrive. How do you categorize failure to thrive?
Below the 90th percentile.
What'd y'all say?
I said below 5%.
Below the 5th percentile.
Yeah.
Okay, especially on weight. I thought somebody said 95 and I just about died. All right, diaphoresis during feeds. We know that babies don't usually sweat, not the little bitty ones anyway. If they're working so hard to feed that they're sweating, we got a problem, yes?
Yes.
Why would they refuse to eat lying down?
Because they can't breathe?
All right, so if you'll know that with cardiac patients, how do we sit them?
Semi-fowlers, or if they're have the cleft palate or cleft lip 90.
We're not talking about cleft lip, cleft palate.
Oh, semi-fowlers, no?
Yeah, like any of our cardiac patients, you want to sit upright, like high fowlers usually, right?
Oh, high fowlers, yes.
Okay, because the lower down a cardiac patient is, the harder it is for them to breathe, because all that fluid is going to weigh down the lungs, yeah? Okay, so if they refuse to eat lying down, because when you lay them down, that heart isn't beating correctly, they're not getting oxygen, and then they're not going to be able to eat. Yes?
Yes.
Okay. Heart rate consistently over 160 or under 110. I've been saying that since y'all walked into Pedi. Tires easily during feeds and falls asleep. Why would they get super tired during their feeds?
Because
they're burning so much calories.
They're working so hard to breathe and they're burning so many calories. Both of you are right. So when this baby is working so hard to eat and to breathe at the same time, they're going to tire out very quickly. Now, a lot of babies fall asleep at the breast. That's normal because they get a little bit full, and y'all know how you feel when you get a little full. You want to take like a little nap, you know? But those babies are really easy to wake up by like rubbing the bottom of their foot, or just like gently undressing them a little bit, or switching breasts or something like that, right? But these babies will like ravenously want to eat, and then they tire out very quickly. They fall asleep and they're difficult to arouse. Okay. Cyanosis at any time, never normal for a baby, except acrocyanosis in what age group?
Infants.
Newborns.
Right? In the first couple of weeks of life. But if any child is cyanotic, not normal. You with me? Yes? No?
Yes.
Okay. Good. Thank you. All right. Understanding the fetal versus the newborn heart. So here's prenatal, here is postnatal, and I can make it a little bit bigger too. Let me do this one over here. This one's a little bit bigger. All right. So every baby born has 2 holes in the heart. Where are they at?
The PAD. It's where the pulmonary artery and the pulmonary by the aorta, no?
All right, yeah, this is called a
pulmonary
PDA,
vein,
right?
The PDA.
Patent ductus arteriosus. What does patent mean?
Open.
It's open.
Ductus.
The duct.
There's a duct. Arteriosus.
Artery.
Between the arteries. So there is an open duct between the arteries. So here it is right here. There's a hole between the aorta and the pulmonary artery. What is the purpose of the PDA?
It bypasses.
Go ahead,
Michelle.
It
bypasses the lungs when they're in.
It goes into the lungs. We need more lung blood flow, right? Because remember, when babies are in utero, their very little to no blood goes into the lungs because they don't need the lungs to oxygenate when they're in utero. Because where does a baby get all their oxygen from?
The mom.
They get it from the mom, right? The mom gives oxygenated blood to the baby. So not very much blood needs to go to the lungs. But as soon as that baby takes the first breath, they get a signal, oh, now I'm grown and I got to actually oxygenate my own blood, which means we need more pulmonary blood flow. So the PDA is there to shunt blood from the aorta into the pulmonary artery so that they can get more pulmonary blood flow. You understand? It's meant to be there. It's supposed to be there. If it's not there, then those babies will have a very hard time oxygenating. Now, for cardiac and PD, you have to look at which parts of the heart are the highest workers, because we know in everything in our body, it goes from high to low. Everything goes high to low, right?
Yeah.
What's the hardest worker of the entire heart? What's the hardest?
The left ventricle.
That's right, because the left ventricle has to work against
Against
gravity and pump out to the rest of the body. So we know the left ventricle is a harder worker. So if we're looking at shunts, the majority of the shunts today are going to be left to right shunts, because if there's a hole here, a hole here, a hole anywhere, the left side is working harder than the right. So it'll go from high to low pressure. Can y'all see my mouse moving?
Yeah.
Okay. If there's an exception, I will let you know. Now let's go up here and talk about the same thing. Which one is bigger, the aorta or the pulmonary artery?
The aorta.
Aorta. So this shunt is going to bring blood from here and it's going to squirt into the pulmonary artery and bring more lung blood flow. Now, when should the PDA normally close?
Is it 9 months? Or no. It's the first few
2
weeks,
to 3
right?
days.
First couple of weeks. Okay. Yeah. A couple of days to a couple of weeks. If the baby is normal and healthy, this will go away. And because the baby's now oxygenating their own blood and they're getting plenty of lung blood flow. You with? Second hole is between, it's kind of hard to draw because it's, this is 3D, but it's a hole between the right atrium and the left atrium, right across here where the septum goes. Do you see the septum goes all the way up underneath here? It divides the heart into left and right. The hole is between the right atrium and the left atrium. Okay. So if you have some blood flow, the left side we know is the hardest worker. That's going to be a left to right shunt, right? And that's, again, going to give more blood flow to this right side so that we can get more pulmonary blood flow. You'll understand.
So this one's bypassing the lungs then, right?
No, it's going
The
from left
From the right atrium to the left atrium, right?
The left side works harder and you go from high to low. So it's going to be a shunt from the left side to the right side. So blood that's over here is going to shunt over to the right side. So that's going to give us more blood flow here and then more lung blood flow.
Okay.
You see what I'm saying?
So it's going to go from the left atrium to the right atrium.
Most things go from left to right. Y'all understand what I'm saying?
Yeah, I think so.
Well, I need you to really understand it because it's like the basis of this whole thing.
You said it's going to go from... So what I'm understanding is you're saying that it's going from the left atrium because that's the higher volume to the right atrium.
Right. And so that's going to give more blood flow over here, which is going to bring more blood flow here, which is going to pull more blood flow into the lungs.
Okay. Gotcha.
And again, the PFO will close in a couple of days to a couple of weeks.
Okay.
These things are meant to keep this baby alive.
But whenever we get blood from the superior and inferior vena cava, we're doing the first normal cycle of the heart, which will be right atrium to right ventricle. Then it goes. So it wouldn't do the whole circular thing. Why from the right atrium wouldn't it? That's what's confusing me. Like, how would it go from left to right if we get the blood from superior vena cava to inferior vena cava?
Because a lot of blood that's on this side is going to squirt over to this side.
So we're still doing the normal heart, but once it goes to that left atrium, it will.
Same. It's just giving it a little extra blood to this side.
Okay.
So when this beats, it's going to squirt some of that blood over here so that the lungs can get a little extra blood flow.
Okay.
Does that make sense?
Mm-hmm. All
right. And this is the same concept. I'm trying to get more lung blood flow. So that's why these are going to stay open for a couple days to a couple weeks, unless we need to force them open for whatever reason, which for a lot of these defects we will, because we need more lung blood flow. Do you understand?
Yes.
Okay. So eventually, as you can see, this will close. Okay. And this is going to go away and this is going to close and it will be just like a normal heart. But that'll take a couple days to a couple weeks, depending on the baby. That's why most murmurs in infants are normal, because you may hear a murmur here and you may hear a murmur here. What is a murmur?
The swishing.
Whoosh.
Yeah, it's a turbulent blood flow, and you're going to hear a swish as it goes through this little duct, and you hear a swish as it goes through this little hole. Right? So if I hear a murmur on a newborn, depending on where I hear it, most of the time it's going to be normal unless the kid is symptomatic. And if they're symptomatic, then that's not normal, meaning they have cyanosis, poor feeding, diaphoresis, all those red flags that we gave you.
Mm-hmm.
Do you understand what I'm saying?
Yes.
Yes, ma'am.
All right. So This is what we may see on an exam, on physical exam, okay, is in a newborn, we might see mottling, which is normal in a newborn, but not in anybody else, because they're trying to figure out this whole circulation thing, right? And as their body starts to change that heart, obviously the most vital organs are here. So you may see some peripheral cyanosis, which we call basically acrocyanosis. Their extremities may be a little cooler. They may have a little mottling because they're still perfusing straight down. Okay. As they're not a newborn anymore and we go to this part of the heart, the regular heart, then they shouldn't have those symptoms anymore. But you'll see if you ever go work in the nursery or in the NICU, it is so important to keep these babies warm, because if they get cold, what happens?
It shunts from the extremities and it just goes central.
It's already shunted from the extremities, so now it's going to have to shunt from a different organ. And what's the most common organ that usually gets shut down in these NICU babies?
Your kidneys.
GI.
It's the GI, and they'll get what disease?
Oh, the neck.
The necrosis. Yeah.
That's right. Do y'all understand what I'm saying?
Yes.
All right. So you understand the two holes and we're good to go?
Yes.
All right. So we're going to start with an ASD. So each of these will be drawn for you. You need to understand where the shunts are going, and that will help you to follow where the symptoms go. All right. So an atrial septal defect, remember this right up here is the septum. It separates right from left. So an atrial septal defect is a hole right here. Now, oftentimes this gets misdiagnosed as a PFO because every baby has a hole between the atrium, right? Right?
Yes. Yes.
So it's hard to detect whether it's a true ASD. Now, last time we were in session together, I was telling y'all about Bacterial Association, the Bacterial Syndrome, that they were concerned that Emmy had. And we did an echo, and they actually did diagnose her with an ASD because they got the echo done when she was like 2 days old. After we got out of the hospital and we went to cardiology again to determine how bad the hole is, they did it again and there was no hole. Now, did she spontaneously heal?
No.
No, somebody misdiagnosed it. Well, could have. God is good. But it could be that when they did the echo, they misdiagnosed a PFO as her ASD.
What's the PFO?
The patent form and ovale.
Okay. Got you.
Okay.
Yes, it's the hole. Yeah.
Yep. All right. So, but this is an actual true hole. It's not a PFO.
It's not normal, right?
Okay. So because the left side works harder, you will see a left to right shunt. Okay.
So I have a question. So they think it, do they get those two confused because that's where the same exact, the PFO is, where the ASD is?
Yes.
Okay. Got it.
So it's hard to tell. So most of the time, if we see something there and it's, we'll just repeat the echo in a couple of weeks or a couple of months, depending on if the kid is symptomatic. And if it spontaneously disappeared, either it was a small ASD that just closed on its own, or it was just the PFO.
Okay.
All right. So the ASD is the hole between the atria. You'll see a left to right shunt, right? So that just means that a little bit of oxygenated blood from this side is going on to this side. Because there is no problem with them getting plenty of blood to the rest of their body. This is not a cyanotic defect. They will not present as cyanotic. And a lot of these go undiagnosed for a long time because there's really not very many symptoms. Okay. And I'll show you what I mean by that. So they are very big on testing adjectives on murmurs. This is what I mean right here. So each of these defects will have a different type of murmur. These adjectives in front of it are highly testable. And that's for NCLEX as well. Okay.
So like the systolic ejection murmur?
Right. They'll say like upon, examination, you note that the baby has acrocyanosis, and they have a systolic ejection murmur. Which cardiac defect would you suspect? And you would have to know that that belongs to ASD. Do you understand what I'm saying?
Yes.
Okay. All right. So if this opening is very large, okay, now a small opening probably won't have any symptoms. That's why it's asymptomatic. And for kids, if they're asymptomatic, we are not going to cut open their chest and do a massive heart surgery. That's insane. So if they're asymptomatic, as long as it's not a cyanotic defect, most of the time we give these kids until they're a year old to Okay. And we don't do anything. We just kind of watch them, we monitor them. And then if it's still present after a year, then we might consider doing something. And that's for all of these defects that are acyanotic, meaning the kid doesn't have cyanosis. There's no real symptoms. Do you understand what I'm saying?
Yes, ma'am.
All right. So in this defect, you're going to have a left to right shunt because the left works harder than the right. You with me?
Yes.
Yes.
If it's a large opening, they might present with mild symptoms of heart failure, either right or left. Because if the blood over here is shunting over here, then that's like double the blood volume going up into the lungs. So they might present with these symptoms like dyspnea, respiratory infections, pneumonia, like your normal, what you would usually see left-sided heart failure looking like. Or they might present with activity intolerance, and this was something that's kind of funny because when I was doing my preceptorship for a nurse practitioner, the doctor that I worked with, he was an older doctor. He's brilliant. He would always go into the room if he had a well visit. And the first thing he always asked parents, he's like, "Hi, I'm Dr. Reynolds. How y'all doing? How is so-and-so? Is he running around and keeping up with everybody?" And I thought he was just like, making small talk. But so I finally just asked him, like, why do you say that to every single mom? And he's like, because that's something that parents notice. If your kid is running around and playing and he's unable to keep up with other kids, like he has to stop when they're all running and he can't keep up with them. So that's a good way to ask, because you can't just say, like, does your child experience activity intolerance? Like, nobody knows what that means. You know what I mean? Or he'll, a lot of parents will just say, like, oh yeah, he runs around with everyone. He gets really tired after he plays. That's a big red flag for us, right? So it's a good question to ask. Is he, are they running around and keeping up with everybody? And but I will tell you, as far as a nursing perspective, activity intolerance is never a priority nursing diagnosis. Okay. Because if your kid has activity intolerance, you need to tell them just to sit down, right? And I'll go deal with the other nursing diagnoses that are more dire. You understand?
Mm-hmm. Yeah.
Okay. But most of the time, these are asymptomatic. And a lot of kids, we won't even know they have it until they're older because they weren't symptomatic, because we don't do echoes on all kids. Okay. So what is an echocardiogram, by the way?
That's a picture of your heart.
Right. So it's in real time. Okay. And you can actually see the valves opening, the valves closing. You can see it'll show blue blood if it's unoxygenated, red blood if it's oxygenated. So you can actually watch the heartbeat in real time and see what's going on inside the heart. Okay. Mm-hmm. So while we do that, we will see, oh, there's an opening here and there's going to be a purple color right here because red and blue are mixing. You understand?
Okay. Yeah.
All right. So if it does not, okay, so we give them for the first year of life, right, to close if they're asymptomatic, right? If they're asymptomatic, we don't do nothing. I'm not cracking open your chest because, you got a little hole that may close. So we give them till the whole first year of life. And if it doesn't close or the patient does become symptomatic, then we're like, oh, you got a hole? Let me just patch it. So we go in through cardiac cath, okay? Because again, I don't want to, these open heart surgeries, I don't know if you've ever seen them on YouTube or anything, they're ugly and they're very dangerous, and they got to crack open your entire sternum and you're stapled back together and you have to go on a bypass machine, and they're very, very dangerous. So unless I absolutely have to, I'm not cracking a chest, right? So they can actually go in through the femoral artery and go through cardiac cath and just put a tiny little Band-Aid right here. It's just a little patch. It is called a Dacron patch, and that is highly testable. Okay.
Got it.
All right. So as far as nursing care for a kid that we know has an ASD, of course, I'm going to auscultate for crackles, because if they have crackles in there, that tells me they are symptomatic and I do need to report that. Yeah.
Yes.
We're going to sit them upright just like we do all of our cardiac patients so they can breathe well, watch them for cyanosis. We got them on a pulse ox so that we all know if they're not breathing well, right?
I thought they wouldn't get cyanosis though.
Most of the time they don't. But if it's very severe and their lungs start to fill with fluid, then you might see cyanosis.
Okay. Only if it's severe.
Right. So oxygen, they only need it if they're cyanotic or if their pulse ox goes less than 95, which is very rare because it's an acyanotic defect. Okay. Now they like to ask these types of questions here. What do you tell, parents, a child has been diagnosed with an ASD and they're taking the baby home. What activities is this child allowed to do? Well, we let the kid decide what activities that they want to do. Of course, we're not going to have them do WWE or football or anything. But as far as what the child can tolerate, You can't force a child to sit down. I'm sorry, you can't. It's mean. So we just say like, hey, let the kid run. And when they're tired, kids will sit down. So you just kind of let them decide. When they get tired, they sit down and that's it. Got it?
Yes.
Got it.
All right. Another big common testable thing is this often appears in kids with Down syndrome. It's very common for Down syndrome kids to have heart defects as well. And this is one of them that you might see. So as soon as a Down syndrome baby is born and they're stable, then we will schedule them for an echo because it is so common for this to occur. Yeah, with me?
Yes.
All right. Next one is a VSD. So same concept, just down at the bottom. Ventricular septal defect. It's a hole between the left ventricle and the right ventricle. What type of shunt will you see with a VSD? Hello?
Yes.
I'm looking for it. Okay, there we go. I couldn't find it. VSD. Oh, this would be your lower this would be your ventricle. So wouldn't it be left ventricle to right ventricle?
It's what?
Left ventricle to right ventricle. So it'd be
it's still going to be a left to right shunt because the left is still the hardest worker of the heart, right? Which is why you see some of the blood right here coming over into here. Okay, this is not a cyanotic defect because they're still getting plenty of oxygenated blood up into the aorta. Okay, they're just getting a little extra blood flow over here. Okay,
to the right side.
It's a left to right. That's right. This one also appears with Down syndrome. So ASD and VSD, very common with Down syndrome kiddos. Again, usually asymptomatic. Okay, because nothing's really happening other than a little bit of mixing of blood and some going from the left side to the right side. The adjectives for a VSD is pansystolic or holosystolic murmur. Okay. And again, usually it's asymptomatic, right? Because all we're doing is mixing a little bit of blood. But if it is a large opening, same thing as we saw with the ASD, you might present with signs of heart failure as you get extra blood flow here that goes into the lungs. Okay. If the defect is super large, like let's say this is a giant hole right here, there's a lot of mixing and you're going to get a lot of blood flow over here. That's going to go into the lungs. So they're going to start drowning in those lungs. So it can lead to pulmonary edema. And what sign and symptom of pulmonary edema might you see?
Pink frothy sputum.
That's right. So if in a VSD kid, I see pink frothy sputum, that is a red flag. Well, it's a red flag for anybody, to be quite honest, but you might see it more so in a VSD. Okay. We're again going to diagnose it with an echo. If they're asymptomatic, what do?
You wait for a year, and then after the year, you're going to do the, you patch the hole.
We're going to patch them up. Okay. Same thing as we saw for ASD. You're going to auscultate for crackles, sit them upright, watch to see if they make sure they don't turn blue for any reason. Pulse ox, oxygen only if their pulse ox goes low, and let the child decide what activity they want to tolerate.
Amber, would it be the Dacron patch?
It's not called the Dacron patch, but it is going to be a patch.
Okay.
Okay. All right. Do we understand VSD?
Yeah.
Yes.
All right. Next, we're going to go to the PDA. I'll give y'all just a second to find that one.
Oh, I got it.
Got it.
Michelle, tell me when you're ready.
I got it.
All right. So we already said that a PDA is normal. The PDA that we're talking about here is if it fails to close in a couple of weeks or if it's really large. That's when we would actually say like the kid's diagnosed with a PDA. Do you understand the difference?
Yeah.
Okay, because every kid has a PDA and it's normal because it's small and it's asymptomatic and it closes in a couple of weeks. If for whatever reason we heard a big murmur and we re-echoed that kid in a couple of months and the PDA is still open and it's large, we'd be like, okay, that's not normal, right? It's persisted longer than it should. Okay. Now, remember, babies have to have a PDA when they're born to get blood flow to the lungs. That's normal, right? Okay. Yes. But we're talking about a big one or failure to close. Okay. So with these kids, again, usually asymptomatic because they're just getting a little extra blood flow to the lungs and the lungs can handle the extra blood flow. Okay. But they do have a lot of extra blood flow in the lungs. So it may make it a little bit more difficult for them to feed. So they may have a hard time gaining weight. Okay. The adjective that we use to describe this one is a machine-like heart murmur. You know how like when your computer like goes into overdrive and it's like that? That's what it sounds like. That's why it's called a machine-like. Okay. Yes. And then again, you're going to see the same thing we've already done. If it's a large opening, you might see signs of heart failure because it's dumping a bunch of blood into the lungs. Again, could lead to a pulmonary edema if the defect is large because they're getting a bunch of extra blood flow in the lungs. It's going to fill up those lungs with fluid. Does that make sense?
Yes.
Okay. Again, we're going to diagnose with an echo. What do you do if they're asymptomatic?
Wait a year and then you close the PDA.
Yep, we do nothing. And then if it's been over a year or they're symptomatic, this is highly, highly testable right here. You can attempt to close it pharmacologically by giving them indomethacin.
Oh, yeah.
Do you remember indomethacin from pharm?
Yes, it closes the PDA. And it's an NSAID.
That's right. And so we are not supposed to give it to pregnant women because it closes the PDA. But in this kid, we want to close
you want to close it.
But keep in mind, it still is an NSAID. NSAIDs are toxic to what? To organs. Keep it in mind. Think about it before you say it.
The liver?
No, you say that every time. That's why I said think about it.
Okay, hold on.
Okay, back to the drawing board. NSAIDs, toxic to which organ?
The kidneys?
Kidneys and? What do you have to do before you take an NSAID?
Heart?
No.
Before you take ibuprofen, what are you supposed to do?
Who? Oh, your GI?
Yes. You've got to eat right before you take NSAIDs. So you got to watch that stomach lining because it can cause like peptic ulcer disease. And
yeah.
Remember, it's a toxic blocker. Okay. So we're going to do the same nursing care we've been doing this entire time. Auscultate for crackles, sit them upright, watch for cyanosis, put them on a pulse ox, oxygen if they go less than 95, let them decide what activity they want to tolerate. Got it?
Got it.
Questions on the PDA?
No.
Okay.
No.
All right, let me see if I want.
Okay. No, actually, I do have a question. Okay, so you would wait for a year and then give them the indomethacin when if it doesn't close?
No, if we wait a year after the PDA, then they'll usually surgically close it. If it's a little baby and they have other heart issues and we need to get it closed, or we notice it's already a big defect or they're already cyanotic, then we would give indomethacin. But mostly we do indomethacin on the little ones.
Okay. But like on testing purposes, when would it just ask you like what kind of medicine?
Yep.
Would you give? Okay.
Yeah. All right. Do we understand all of these? Everything we've done so far?
Yes.
All right. Now we are going to let's see. Let me see where I want to go. Hold on. Go to coarctation of the aorta.
The what?
Coarctation of the aorta. We've talked about this one a lot, but y'all may not remember. This is the one we remember before they're 3, you have to do an upper and lower blood pressure at least one time.
Yes.
We talked about that in growth and development.
Mm-hmm.
The what?
At one time before they're 3, you have to do an upper and lower blood pressure on the patient and compare upper to lower.
Oh, yes.
All right. So this is the one we're doing that for. So a coarctation is a defect where you can see that the aorta is squeezed. Y'all see this?
Yes.
All right. Mm-hmm. So behind that, the pressure is going to be very
high,
low to the body.
And then on the other side, it's going to be very
low.
It's just like if you take a water hose and you bend it in half. Y'all done that before? Like clamp off a water hose?
Yes.
Mm-hmm.
Okay. So the water pressure behind it is going to be very high. And what does it look like when you clamp a hose? What's coming out the end?
Little to nothing.
Just dripping.
It just drips. So that means that in this kid, the blood pressure up at the top extremities is going to be very, very high. And then in the low extremities, it's going to be
very low.
Low. That's right. Okay. So that's because there's so many kids that this gets misdiagnosed or just doesn't get diagnosed because it's not a cyanotic defect. They don't usually have symptoms. That's why the AAP came out and said, hey, we have a new recommendation that at a well visit, you can pick one. I don't care which one, but at least one time you have to do an upper and lower blood pressure and compare the two. Okay.
Okay.
All right. So this is more common in Turner syndrome. Have y'all ever heard of Turner syndrome?
This is the one when they look like a girl, right? The boys?
No, it's a girl, but they look like, I'll show you what it looks like. It looks like, they look like little gymnasts. They usually have very short,
they have a short neck.
Yes, they have like a wide neck. Okay.
Neck.
Yeah. And so they usually are not fertile. Okay. My computer's going so slow for some reason. And a lot of times Turner's doesn't get diagnosed either because, I mean, of course,
isn't that a genetic?
It is a genetic disease. Yes.
Genetic disease, right?
Yes. So they're little teeny tiny. Their ovaries don't usually develop. So that's why a lot of times they are not fertile. Okay.
Okay.
Now, of course, Google's going to give you the most extreme. Okay. Like this. This is very extreme. Y'all can see what I'm doing?
Yes.
Yeah.
Okay. But some of them are a lot more subtle and you may not be able to tell. Like this obviously is very obvious. Okay. But some of them are not. Okay. But you can see like in these kids, like they have the wider neck. They're little teeny tiny little girls. Okay. Very short stature.
Yeah.
Look, I mean, you can tell that they have some type of syndrome sometimes, but sometimes you can't. Okay. So it is common in Turner's. Okay. Now Turner's only happens to girls. Okay. However, this defect overall,
the one with the K is for the guys, right?
Oh, like what's the other one that looks like that? Yeah, if they're a boy, usually, yeah, Klinefelter's is kind of similar to
Klinefelter's. There you go.
Yes.
Okay.
So this is more common, or it is common in girls with Turner's, but it's more common overall, like as far as numbers in boys than with girls. Okay. Again, it may be completely asymptomatic, and most of the time it is. But if they do have symptoms, remember they got high pressure up top, low pressure on bottom. Okay.
Okay.
Their legs and feet may be more cool. They may have some modeling. The pulses may be a little decreased. But these are people that like, usually how we see them is the parents will bring them in and they're like 3 or 4, sometimes older. And they're like, oh my God, her legs are cold all the time. She's always complaining that she's cold in her legs. You probably know people like that, you know? It gets it's very undiagnosed. Okay. Like, so it could lead to heart failure symptoms if it's very severe, because over time it can get worse. So if this is pinched off, you're going to have a backup of blood flow down the aorta. You're going to have a lot more blood volume in the left ventricle, which is they're going to back up into the
lung.
Right. And so you may see left-sided heart failure symptoms if their defect is very severe. Okay.
Okay.
Again, we're going to diagnose with an echo. Okay. And if we need to fix it, we're not going to open up their entire chest because this is not life-threatening immediately, right? So we'll go in and cardiac cath. They're going to feed it through with cardiac cath, and they're going to go in and put a big old balloon and pop it back open, or they'll put in a stent. Okay. You with me?
Yes.
Yes.
Okay. So they can coarct later in life too. Like if you just go in and do the balloon and like blow it open, and then they obviously have to pull the balloon out. You can't leave a balloon in there. It is possible that the defect could re-happen, I guess. And it could squeeze again, and you might have symptoms again later in life. So it's something you always kind of have to look for. Okay. So because this goes so undiagnosed, at least one time before age 3, every kid needs 4 extremity blood pressures to compare upper to lower. Okay.
Yes.
Monitor peripheral pulses because the lower pulses may be lesser, right? Most of the time they're not absent. Because if it's absent, obviously that's an emergency. They're just a little bit decreased. And most doctors or nurse practitioners may miss it even during a well visit because it's very subtle. All right, auscultate for crackles, because if it is very coarced, we're going to back up here, back up blood into the left, and then back up into the
body.
Lungs.
Good.
Okay. All right, do we understand coarctation of the aorta?
Yes.
All right. Now let's go to, hold on, let me see where I want to go. Okay, let's go to our cyanotic defects now, the big, bad, ugly ones. Okay. So all those ones that we just did were acyanotic defects, right? We're not popping open their chest. We're fixing things as easy as we can. We give them a lot of time for it to fix itself. These next ones that we're going to cover are cyanotic defects. The baby is born blue, so we got to move immediately. Okay. Things to note about the cyanotic defects, both like just as kind of a whole. Okay. Cyanotic defects, obviously the baby's born blue, so you're gonna have to bag them and stuff like that, right? They're gonna need oxygen, okay? But you got to be really careful with the oxygen that you give these babies, because what was the whole reason for the PFO and the PDA? What's the whole purpose of having those open?
Like before it closes?
Yeah.
Oh, well, I guess it was just to get the blood circulating.
It gets blood where? Where do we need the blood?
In
the lungs?
In the lungs. So it's to get more lung blood flow. Yes?
Yes.
Okay. So these babies really need lung blood flow, okay? But with the cyanotic defects, what happens naturally when those PFO and the PDA closes and you have a cyanotic baby already? We got
That's
a problem.
bad because
We got a
there's
problem.
no blood to the lung.
And what tells your baby to close the PDA and the PFO? What signals to their body, hey, you don't need these holes anymore?
If the
Isn't
mom
it
has
at birth?
incest?
What did y'all say?
I said at birth whenever.
The prostaglandin?
No. Okay, based on what we said, the purpose of the holes was to get more lung blood flow so they can get more oxygenated blood.
Yes.
So what would be the signal to your body? We don't need these holes anymore.
Oh, if you're saying like you don't need any more like blood, like your heart, or would it be your lungs?
It's the signal to your body, hey, you have plenty of oxygen. So if you have plenty of oxygenated blood, then I don't need these holes anymore and I can close. So
That
what
should be
happens is if you have a baby that's born with a cyanotic defect, they're blue, and you give that baby a whole bunch of oxygen, what does that tell their heart?
To close
we
it.
don't need no more.
Exactly. And it's going to close their PDA and close their PFO, which can be life-threatening for these babies with cyanotic defects. So for all of these cyanotic defects, we are going to let these babies sat very low. Like if you go into the CVICU, you will see their pulse ox in the 70s and 80s, and we let them chill right there.
Yeah.
Okay. Because if I give them a whole bunch of oxygen to get their SpO2 up to 96%, that's going to signal to their heart, oh, we don't need any more oxygen. Close the PDA and close the PFO. And as I'm about to show you on these different defects, when those close on these cyanotic defects, that baby will pass away because now there's no more lung blood flow, or there's not enough oxygenated lung blood flow. You understand what I'm saying?
Yes.
Okay. So we're going to let these babies sat low. Like in the 70s to 80s is where we're going to let them sat until we can fix their defect. You got me?
Yes.
Yes.
Okay. So let's go back and talk about it. All right. Tetralogy of Fallot. What does tetra mean?
Tetra? I don't know.
Isn't it behind the
Your hand?
Anyone?
Behind the how's it called? The aorta?
What are y'all saying?
You said where's the Tetralogy of Fallot?
No, I'm asking what does the word tetra mean?
Oh, tetra. What does it mean?
4?
Yeah. Tetra means 4. What does tetra mean?
Oh, 4.
All right. So in Tetralogy of Fallot, there's 4 cardiac defects that are leading to this heart problem. Okay. So you need to do it in this order, because if you don't do it in this order, it's going to be kind of confusing as to where the blood flow is going. All right. So we're going to start with the defects, and I'm going to show you where the blood flow is going and what the problem is with this baby. All right. Number 1, we have pulmonary stenosis. So right here in the pulmonary artery, it is stenotic. What does stenotic mean?
Stiffening?
Yeah.
Like a small narrowing, right? Stenosis means to narrow. So you can see their pulmonary artery is very tiny. Okay. And you can see the pulmonary artery is this pulmonary valve is very narrowed as well. So that means that the blood is going to have to be pushed really hard up here, but these babies don't have that type of muscle, cardiac muscle yet, right? So as you can see, that's going to put a lot of pressure on the right ventricle to have to push really hard to get that blood flow up this stenotic pulmonary artery. Are y'all with me?
Yes.
Because the right ventricle is having to work so hard to push it up in here, it's going to get very big, and that leads to right ventricular hypertrophy, an enlargement of the right ventricle because it's working so hard to push that blood up into the pulmonary artery. Do you understand that part?
Yes.
Yes.
Okay. Then the third defect is the baby has a VSD. What is a VSD?
Ventricular
hold on one
septal
second.
defect.
Sorry, Amber, grades are out.
Oh, hell.
Oh, grades? Okay.
Okay, this is, take me 1 second.
Hold on, let me pause this.
I want to see. I am scared.
Just for those people watching this later, they made very good grades. Okay, just letting y'all know the grades were excellent. Okay, so now we move on to number 3 defect of Tetralogy of Fallot, which is the ventricular septal defect, which you guys just told me is what? What's a VSD?
It's from left to right.
But what is it? What's a VSD?
VSD?
Mm-hmm.
Hold on, sorry. The VSD, that was the hole in the
bottom.
Right.
No.
So you can see they have a hole right here. Okay.
Mm-hmm.
Y'all with me?
Yes. Yes.
Okay. All right. So you got the hole that's right here between the ventricles. Okay. And, but the thing is, yes, usually almost all these defects that we talk about are left or right shunt. But remember, look back up here, right ventricular hypertrophy. In Tetralogy of Fallot, which side of the heart is working harder?
The
left ventricle?
The left ventricle?
Yo, what's number 2 on their defect?
Where do you see? Oh, the right ventricle.
Right ventricular hypertrophy, right? This one is going to be enlarged and bigger and stronger because it's been pushing all of this.
All the extra. Okay.
So this is an exception to the rule. This is usually going to be a right to left shunt. Okay. Do you understand why?
Yes, because now, okay.
Now this side is the bigger daddy, okay?
Okay.
All right, and then number 4 defect for Tetralogy of Fallot is they have an overriding aorta. So you can see where the aorta is, and it overrides into both sides. So as the aorta, which takes blood to the rest of the body, is picking up blood, you see how much unoxygenated blood it's picking up.
Mm-hmm.
It's picking up some oxygenated blood, but mostly deoxygenated blood and sending that to the rest of the body. That's why when our babies are Tet babies and they're born, they are blue, like cyanotic blue, because all the blood flow, even if it's coming from the left ventricle, because it's mixing, they're getting mostly deoxygenated blood sent out through the arteries to the rest of the body. Does that make sense?
Can you repeat that? Sorry.
Which part?
The whole part that you said with the blood mixing, and then that's why they're blue.
Okay. So because they have right ventricular hypertrophy, the right side of the heart is the harder worker. So this is going to be a right to left shunt. There's going to be a lot of mixing of deoxygenated blood right here, and they have an overriding aorta. So the aorta is picking up mostly deoxygenated blood and sending that out to the rest of the body. That's why when this baby is born, they are cyanotic.
Blue.
Okay?
Okay.
And in order for this baby to get pulmonary blood flow, they have to have a PDA, because look how much pulmonary blood flow is going to be able to go to this baby. Because this is so stenotic, how much lung blood flow do they get?
Little.
Very little. So in order for this baby to live, to survive, they have got to have a PDA open. So what can I not do for this baby?
You're not going to give them endomycin, and you'll give them prostaglandins?
Well, yes, but what tells the PDA to close?
Oh, oxygen. So you're not going to give them O2.
Exactly. So I'm going to give them O2, but just a little bit, and let them sat low so that I don't lose my lung blood flow. Okay. And then on top of that, in order to keep that PDA open, this is also highly testable, we will give them prostaglandin E, which will keep that PDA open. Okay. What do Papa prostaglandins do?
They're pain producers.
Right. They tell your body,
something is wrong.
So if the heart knows something is wrong, it won't close the PDA because it's getting a signal that something is wrong.
Okay.
So we're going to let these babies sat low so that that PDA does not close, because I got to get this baby into surgery. But most hospitals will not do surgery on a baby until they weigh 8 pounds, because that's how big they really need to be able to metabolize anesthesia and those type of things. So our goal is to get this baby to 8 pounds so we can get them into surgery. But I need to keep these things open until they get big enough to get into surgery. Do you understand?
Okay, got you.
Okay. Because the pulmonary artery and the pulmonary valve is stenotic, there's something wrong with the valve. What have you guys learned happens when there's something wrong with the heart valve?
They're pissed off forever.
Exactly. So this baby will have a lifelong risk of endocarditis and will need prophylactic antibiotics for procedures for the rest of their life. Do you understand why?
Yes.
All right. So when this baby is born, they are blue. So we're going to bag them and we're going to give them just a little bit of oxygen and we're going to get them on prostaglandin, right?
Yes.
Because these babies, they're blue anyway, but they also will have additional cyanotic spells called TET spells, where that baby is not cyanotic. We may have gotten them stable. They're laying in their little bassinet thing, right? We have a little bit of oxygen on them. They're satting at like 85, but they're not cyanotic. Then all of a sudden, out of nowhere, boom, the baby turns blue. That's called a TET spell. Okay.
Okay.
These are the 4 things we do during a TET spell. This is very highly testable. In a drag and drop, what do you do? Okay. So the first thing you're going to do, if you just look over at that baby in your bassinet and you're like, oh, you are blue, you're going to use the calm approach. Don't panic. Don't start screaming. Don't call a code. Don't call a rapid response because you knew that this was going to happen. Okay.
Okay.
You're going to immediately put that baby in a knee to chest position. Y'all know what I mean by that? You're just going to fold their body. All right, knee to chest. Just wrap them up like a little fetus, like they were when they were inside mom. Okay.
But for older kids, don't they squat?
Yeah, because obviously I'm not going to be like, lay down and let me bend you in half. Like that doesn't make sense, right? Yeah. So for these infants, these neonates that are still in CVICU, we're going to put them in knee to chest. What does knee to chest position do?
Does it press down on their heart?
No, I don't want to do that, right?
It helps them get more oxygen.
How does it help them get more oxygen?
It's close. Isn't it like closing one of the valves as you do the knee to chest, or like
what?
Is it to make the heart keep pumping more?
How would it pump more?
Because of the pressure?
Well, the pressure would push down. Do y'all know what a modified Trendelenburg position is?
Is the one that the head is like this?
I can't see you, but I think you're thinking of reverse. It looks like this. Hold on. Like that, where they put their legs up.
Oh, the foot is up.
Okay. Now, if somebody's
supposed to come down to the head.
Right. That's what you're trying to do, is to get the blood from their extremities to come down. Now, in a baby, I can take these legs and curl them all the way up on their chest. In an adult, they're not that bendy. Okay. So I'm trying to get all the blood flow from their legs to go up to their heart. So that way I can get more blood flow and hopefully it'll get oxygenated. Okay.
Okay.
All right, so we're going to use a calm approach, right? Everything's okay, little blue baby. And then we're going to put him in knee to chest. And then we're going to give him some oxygen because they are truly cyanotic and blue at this point. So for a very short period of time, I'm going to give him some extra oxygen. And then I'm going to give him morphine. What am I giving morphine for?
To calm them down.
What?
For
what do we give morphine for in an MI? Why do we give morphine? Isn't morphine part of MONA in an MI?
Yes.
Okay, why do I give a MI patient morphine?
For pain.
And what else?
No, it relaxes the heart.
It opens the coronary arteries of the heart, right? So that's why we're giving it to this baby, because morphine, they're not in pain, nothing like that, right? But it's going to open up the coronary arteries, giving more blood flow to the heart.
Okay.
In this order, these 4 things. 4 things for TET, which is 4 things. 4 and 4. You got it?
Uh-huh.
All right. There are 3 different surgeries that this kid is going to have to go through. And these are massive surgeries. Obviously, we have a lot of defects, right? Right?
Yes. Yes.
I can't fix this all at one time. So we're going to wait till this baby gets of the right size. And then we're going to do something called the Blalock-Taussig shunt. Okay. And I'll show you what that looks like, because you're going to see this in several different defects. Okay.
Okay.
All right. So this one is what we call like a palliative shunt. Kind of, we're just trying to get them more blood flow without, we need to do something small, right? A palliative shunt means I just need to kind of alleviate some of these symptoms. Okay. but I can't obviously fix the entire heart. Okay. So what we're going to do is they're going to take a shunt from the aorta to the pulmonary artery or the subclavian, okay, to the pulmonary artery. Why am I doing this? What am I making?
You're sending blood back into the lungs?
Right. And what did we talk about the babies are born with that sends more blood flow to the lungs?
The PDA?
That's right. So I am making a PDA. So that way, if theirs closes, I already have another opening.
Okay, I got you.
Because I can only try to keep this open for so long with, prostaglandin and satting them low and all of that. But once I add my own shunt, now I can give them oxygen and they can sat higher and they'll have this own thing. So that way, if my PDA closes, I'm not that worried.
Okay.
Yeah.
Does that make sense?
Yes.
And that would be palliative. And then they may go home for a while. And usually the second surgery is going to be around, every hospital is a little bit different, but somewhere around 18 months. And then the third one is usually somewhere around 4 to 5 years of age. Okay. So I showed y'all the Blay-Lactosig shunt, and then they're going to go in and do what's called a Glenn procedure. Okay. Okay, let me see if I can find a good one. Okay, this one might be okay. Okay, so you can see here it says the right ventricle is working too hard, right? It's trying to get all this blood flow up into the pulmonary artery, right? So they're going to make another shunt, okay? That's going to be a permanent shunt. That's going to, again, go from like the aorta to the pulmonary artery, okay? And this is going to be able to keep them for their lifelong. Remember, the first one I told you was just a palliative shunt. It's just meant to stay there for a short period of time, so in case their PDA closes. This one is a much more involved surgery. It's much bigger, and this will be their permanent solution. Okay. So that's going to be the second surgery. Okay. And then the last one they're going to get is called the Fontaine procedure. Okay, I'll show you that one.
And when do you do these procedures? Like by what age?
Every hospital is different, but the second one's usually around 18 months and the last one's around 4 to 5 years. Ish.
So the last one is like 4 to 5 years?
Yeah. All right. So in the Fontaine procedure, you're going to get the IVC, the inferior vena cava, is going to go directly to the pulmonary artery. Now, we are basically going to bypass a lot of the blood from the right side. I still need it to pump, right? But this side is so tired, right? And it's hypertrophied and there's not a lot of blood getting through. So instead of having the blood go through here, go down here, this tired right ventricle, pushing, stuff into the pulmonary artery, it's just going to take the IVC and just go straight to the pulmonary artery. Now, some blood is still going to come through here because I still need the heart to pump, right? Mm-hmm. But I'm going to do the IVC directly to the pulmonary artery. So half of the blood that's coming into the heart is going to go straight to the pulmonary artery.
So it's bypassing everything else and going just to the lungs then?
Yes, because that right side is tired. Okay. Mm-hmm. And that'll usually be the last procedure that they'll need. Make sense?
Yes.
Mm-hmm.
Okay. All right. Do we understand Tetralogy of Fallot, the 4 defects, the 4 things to do, the prostaglandin? Let them sat low. Okay. All right. So that one's cyanotic. Let's see. Now we're going to go to transposition of the great arteries or transposition of the great vessels.
Ooh,
this
one's bad.
Yeah, this is very, very bad. All right. What are the 2 great arteries of the heart?
The arteries,
what are the 2 biggest
pulmonary
vessels?
Artery? Pulmonary artery?
Yep. What's the biggest, giantest artery of the entire heart?
The one that the artery that goes down to the kidneys.
So
what is it called?
What's the big giant artery that comes out of the heart and gives blood to the rest of the body?
Aorta.
Okay. So the 2 great arteries of the heart are the pulmonary artery and the aorta. Those are the ones that have the most blood flow.
Aorta,
right?
yes.
Okay.
Yes.
Mm-hmm. So in this baby, those 2 are flipped.
What?
Mm-hmm. I know. This is so crazy. So the pulmonary artery and the aorta are flipped. So that means that blood flow comes into the superior and inferior vena cava, into the right
Okay.
atrium. And this is deoxygenated, right?
Yes.
In here, down to the right ventricle. But instead of it going into the pulmonary artery, it goes up to the aorta and to the rest of the body.
So it's deoxygenated.
It's completely 100% deoxygenated, because then that blood is just going to come right back in, deoxygenated, and go right back to the rest of the body, and come right back in and go right back to the rest of the body. Then on this side, okay, you've got blood flow that's going to be in the left atrium to the left ventricle, and then it's going to go out the pulmonary artery and back into the lungs, and then back through the pulmonary veins, and then in here, and then back out the pulmonary artery and back into the lungs and back through here. So this is going like this in a circle, and this is going like this in a circle. They do not communicate with each other at all. So your lungs are getting tons of oxygenated blood, which they didn't need, and the rest of your body is getting totally deoxygenated blood, which it doesn't need. You understand what I'm saying?
Yes.
So this one's doing its own thing, body to the heart, body to the heart, body to the heart. And this one's going heart to the lungs, heart to the lungs, heart to the lungs. Do you understand?
Mm-hmm.
So what happens with the baby?
The baby is born blue as a blueberry. Okay. You can see here severe cyanosis, dyspnea, poor feeding, poor weight. Like this baby is blue because they're not getting any oxygen. The only oxygenated blood this baby is getting
the PDA?
That's right.
So that's very little.
That's going to close, right? It closes normally?
Yep. And you're getting a little bit of blood through the PFO, but just a tiny bit. So what happens when this PDA closes?
You get no oxygen.
You get no blood.
That's it. You done. Okay.
So in this case, would you give them what is it, prostaglandins until you do surgery then to keep that one open in the meantime?
And we're going to let them sat low, right? Because I don't want that PDA to close. Okay. Now, as soon as that baby is born, though, they will, as quickly as we can get them as stabilized as we can, they're going to go into cardiac cath, and they're going to actually poke a hole through these and make an ASD. Now, why would I want to go and do that?
To transfer the blood.
Transfer the blood.
That's right. So now I'm getting some mixing of blood because I created an ASD. So that will be somewhat to where these two can start communicating with each other.
Okay.
You understand what I'm saying?
Yes.
Yes.
Okay. So, so they're going to make an ASD right here. Okay. So that there's some mixing. And then once the baby meets the weight requirements, they'll do surgery to flip these around. It's called an arterial switch operation. They are switching the arteries.
The arteries.
In an operation. Okay. But again, you're going to require them to sat low. That says requires immediate surgery because they're going to go in and make the ASD. Okay. And then you got to watch. I mean, this is like a one-on-one in the CVICU, crazy medicines, crazy monitoring until you can get that baby into surgery. Isn't this wild?
I mean, do most of them, like in real life, do most of them actually are able to wait until the surgery and survive, or do most of them, like, you know?
Sometimes, that's a great question. Sometimes they have to go to the parents and say, look, here's where we're at. We are only at 6.5 pounds, but he cannot maintain this low of oxygen for very much longer. So we have a big decision to make. He has to have this surgery, but there is a chance that he could die because he's too small. But if we don't do the surgery, he may die of hypoxia anyway. What do you want to do?
That's sad.
It is
very hard.
Yes, this is a very, very difficult choice to make. All right. Do you all understand transposition of the great arteries?
Yes.
Yes? Okay. Let me see. Okay. Now we're going to go to tricuspid atresia. Okay. What does atresia mean?
The artery?
No.
A is without.
That's right.
There's
Tree.
not the flap.
3.
Oh, you don't have the opening between the atrium and ventricle, right? Like there's no connection between those?
Right. So atresia means an opening or a perforation. So if it's atresia at the tricuspid valve, that means the tricuspid valve does not open.
So you won't have no blood going to the pulmonary vein because there's nothing going to the right ventricle.
You won't have it going to the pulmonary artery.
Yes.
Right?
Sorry.
Pulmonary artery. Okay. So because this was developed in utero, okay, remember when baby, oh, you don't, maybe y'all know this, maybe you don't. When babies are in utero, their heart beats only for practice, right? Because remember, they're getting all their oxygenated blood from their mom.
From the mom.
Yes.
So it's only beating for practice. But because they had tricuspid atresia and their heart ended right, like it didn't open very much right here, they either do not have a right ventricle at all, or it's very underdeveloped because it never got to practice and it never built muscle.
Yes.
You understand? So
And
that
then
means
you wouldn't know that until the baby's born, right?
no, you can know at 20 weeks. They do an anatomy ultrasound on all babies, and it includes a very detailed echo of the fetal heart.
Oh, okay.
So we would know. All right, so the blood is going to come through superior and inferior vena cava into the right atrium, and then where does it go?
Back?
Well, there's only one tiny little hole. Where's the hole?
Oh, is it the PDA?
No, the PDA is up here.
Isn't it ASD?
They don't have an ASD.
They don't have an ASD.
Where's
So it
the
doesn't
other
go
hole?
nowhere.
Where's the
I
other
thought
hole?
it would
There's
be back up.
Hang on. When a baby is born, there were two holes. There was a PDA and a
ASD.
Oh, the
PFO.
PFO.
yes.
And that is a hole between the
Right atria and the left atria.
There you go. So in these babies, the blood goes in through the inferior and superior vena cava into the right atrium. It's going to go across to the left atrium, but it's deoxygenated, right?
Yes.
Yeah.
So when it goes to the body.
Ventricle, and it's, yeah.
Ah.
So they're getting little to no lung blood flow. And if they're getting little to no lung blood flow, then none of that blood is getting oxygenated. So what does this baby look like when they're born?
Blue.
Yeah. Okay. So when this baby is born, they are blue. They're dyspneic. They will not feed. They're not going to gain weight. The only thing keeping this baby alive is a PFO. And can I keep the PFO open?
If you let them sat low and give them prostaglandins.
But
Just for a little
prostaglandin doesn't
bit.
keep the PFO open. It only keeps the PDA open.
Oh, I don't know. The shunt?
There's nothing.
There's nothing?
Okay. So because this PFO is going to close in a couple days, right?
Yeah.
Yes.
Okay. Now the PDA is going to be, that is very important in this baby because that's the only way there's going to get any lung blood flow because they're going to bypass the pulmonary artery completely, right? The blood flow goes in through here, squirts to the left side, right? When that blood goes up into the aorta, some of it is going to go down here into the pulmonary artery.
But not a lot.
But not a lot, but at least it's something. So we have to keep the PDA open. So we can keep the PDA open with prostaglandin, but I can't force the PFO open. So we're going to go in just like we did before and make. What are we going to make?
The outer one?
An
one
ASD.
that you had?
We're going to create an ASD just
An
like we did with the
ASD.
last one.
Okay.
And then that way there's some crossing over of the blood.
Like a mix.
Yes, no?
Yes.
And then when you make the ASD, will it start pumping normally?
No, it's never going to pump normally until I do surgery. Well, actually, it's never going to pump normally ever because this baby will never have a right ventricle.
Oh.
So at all, they will never, even when they grow up?
Well, how are they going to get a right ventricle?
So technically, the right ventricle was never there then.
Well, that's like saying a baby was born without a kidney. Are they going to grow one? No, sis, they're not. It's gone. Okay, it's gone.
I thought it was there, but like there was no blood going to the right ventricle.
So it never developed.
I thought it was just underdeveloped. So I thought like when
Yeah.
the blood starts pumping, it's gonna start, magically working.
Oh God. Okay. So what happens if a baby in utero doesn't get any blood flow to their legs and they were born with no legs? Do you think they're just going to grow legs once they start getting blood flow down there? Okay. So if it never developed, then it never developed.
Okay. Got you.
So they will never have a right ventricle. So we're going to go and do the 3 surgeries we talked about earlier. The first was the palliative shunt. Remember in the Blalock-Taussig shunt, we're going to make a shunt from the aorta to the pulmonary artery just in case what closes?
The PDA.
Right. Then we're going to go and do the Glenn procedure where they do another shunt. And then we're going to go do the Fontan procedure, right? So it's the same procedures we talked about in TET.
Okay.
Okay. You're again going to let that baby sat low. prepare for immediate surgery as soon as you can. And then again, you might have to make those decisions, Michelle, you were talking about with the transposition of the great arteries.
Michelle, not Michelle, Amber. So what would happen with these babies after like they get older? Like, do they have to be on certain restrictions because their blood flow isn't like normal?
Most of the time, if they have big giant heart surgery like this, they'll tell you no contact sports, but your activity is going to be as tolerated, you know?
Okay.
But it's something you have to watch on their heart for forever because they could still develop complications.
Okay.
Okay. Do y'all understand tricuspid atresia?
Yeah.
All right. Let's take a quick break. And then we'll go because we're done with the cyanotic defects. And then we will go to, we got to do congestive heart failure, and then we have Kawasaki's and rheumatic fever.
Okay.
Okay. So I'll see y'all back in like 10 minutes.
Okay. Bye.
Okay. All right.
Which one are we doing?
I am going to go to congestive heart failure.
Okay.
All right. So what do you guys know about CHF? We've already covered this before. So what is it?
Fluid overload. The heart got, how's it called?
The heart got what?
Congestive
Where are you?
heart.
Huh?
Congestive heart failure.
Yeah. So what part of the heart is failing?
The heart muscle?
All right. The heart muscle, which is called the
Myocardium.
Myocardium. So you can see what happens is since the heart muscle is weak, it can't beat harder, so it has to beat
fast. I mean, a lot faster,
yeah,
right?
Faster. So they will get tachycardia. Now, most of the time, it starts out with left-sided heart failure because which side of the heart is the hardest worker?
The left ventricle.
The left. Okay. So the left is going to work really hard. They're going to get left ventricular hypertrophy, tachycardia, right? And then eventually, right? Because we know in left-sided heart failure, all the blood backs up to the left.
Oh, no. Sorry.
Can you repeat that again, please?
Sure.
Yeah.
Left-sided heart failure, the blood is going to back up to the
right-sided
lungs. Lungs. And then it'll fill up the lungs with fluid, and then that will back up into the pulmonary artery, and then they're going to get right-sided heart failure. It almost always starts with left-sided, but it will end up being the entire heart like you see here.
Yes.
Okay. But when they just have left-sided, you're going to see left-sided has lung symptoms.
Lung symptoms.
Tachypnea, cough, because they've got all that fluid. They're going to get pneumonia all the time, right? And then it eventually will back up into the right side, which goes to the rest of the
body.
Right. And so then you're going to see things like JVD and the bounding pulses, edema, like all of that is the same as with adults. Okay. We're going to do the workup the same as we do with adults. The first thing we do is a chest x-ray, which will show
the muscle, like not working,
or like no, it's going to show the heart, like hypertrophy, right?
It'll show that cardiomegaly, which means that the heart is very, very
enlarged.
Right. And then we'll do an echo, and the echo shows us what's going on inside of the heart, which will show a ejection fraction less than 55. What's an ejection fraction?
How much is to push the blood to the body?
Yeah.
What is it?
How much the force to push the blood out of the body?
What's this percentage? 55%.
That's the amount of the force.
The what? 55% of what?
Oh, isn't that the blood? Like the force? Like that is
how much has to push to the aorta?
But when y'all say that, what do you like the percentage of force? What is that?
Like 55%.
The 55%, isn't that what it's like? Like how much it's pumping? Like
what?
Like the heart
against the aorta?
Okay. What does ejection mean?
To push
If you were
out.
ejected from a plane, what does that mean?
To push out.
All right. So, and then a fraction means a percentage. So what gets pushed out of the heart?
Blood.
So this is the percentage of
blood being pushed out of the heart
that is ejected out of the heart per beat. So if basically less than half of the blood that's in the heart is being ejected per beat, that's a very low cardiac output. Hello?
So less than 55 would be low cardiac. So the normal, how much would be the normal then?
Over 55.
Okay.
So if you have less than 55% of the blood that is in the heart right now coming out per beat, that is a very weak beat. So you have very little cardiac output, right? Which is what CHF is anyway, right? It's a weak heart muscle that causes low cardiac output.
Mm-hmm.
Okay. And then we're going to do a blood test. There is only one blood test for CHF, and it's the BNP. What does BNP stand for?
Oh, the brain natriuretic peptide.
Very good. Brain natriuretic peptide. And what is a BNP? What does it tell me?
It tells you if they have heart failure.
Right, but what is BNP? What is that substance? That brain natriuretic peptide. What is that?
Isn't it like how heart stomach or like how I can't say it.
Isn't this like the CKMB, like the kinase and?
It is kind of like an enzyme, but like CKMB and troponin. Okay, tell me what those are.
The
I wouldn't say like inflammation or how the heart was damaged. Like,
well, in MI, there's not inflammation, right?
No.
But go to the damage part. The higher your troponin or CKMB, what does that tell me?
The more the heart is not working.
All right, so the higher the troponin and the CKMB, that's an enzyme that comes out when there's heart muscle damage. CHF is not damage, right?
No.
It's an enlargement, right? So BNP is an enzyme that comes out when your heart is stretched. You see the difference?
Oh, okay, okay, I got you.
So the higher the number, the more your heart is stretching because your heart muscle is so weak and can't get that blood out. Remember, we're at less than 55 of the blood coming out of the heart.
Yes.
Okay. So how do we treat heart failure? We're going to do the same thing as we do for adults. We're going to give digoxin and Lasix. You guys need to go back into your farm notes and look at digoxin and look at Lasix just to make sure that you know all the basics. Okay, but y'all know Lasix is a diuretic, right? What electrolyte do you have to monitor with Lasix?
The potassium.
Potassium, that's right.
Yeah.
And then remember, digoxin does two things. It increases contractility, which makes the heart squeeze harder and decreases the heart rate. Okay. So remember when we said you have heart failure, your heart's beating faster but weaker. So you'll hear like a whoop, 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 right?
Yes.
And then when you do digoxin, it's going to slow it down and make it squeeze more. So now it's like a whoosh, whoosh. It's squeezing it and slowing it down so it's not working so hard. So that's how it's able to decrease the workload of the heart. Now, if digoxin is squeezing more blood out per beat, then less of it is backing up to the body. So it helps to decrease edema, right? Because it now makes more blood flow go out rather than go backwards.
Okay.
Okay. So remember when they have heart failure, same as with adults, we auscultate for crackles and we do report that if it's not a baseline for them. This next fact here is often on exams. Digoxin is made as a liquid for children and it's very, very concentrated. So if you get it from pharmacy and there's more than 1 ml of that suspension, then that tells me they gave way too much because it's super concentrated. Okay. So if you get the digoxin from pharmacy and you're supposed to go give it to your patient and it comes up in a 3 ml syringe, you got 3 mLs of liquid. They done messed this up. You need to call the pharmacy and be like, well, first I would check the dose, right? Make sure the doctor ordered the right dose. And then that needs to red flag you that that's too much digoxin. Okay.
Even if the kid's like 5 years old, would that be still too much?
It's super concentrated.
Okay.
So it should never be more than 1 ml.
Okay.
If you give the digoxin and the kid pukes, we do not repeat the dose because I don't know how much of it actually stayed in the stomach. And
So
if
we
I
would
give
just wait for
yeah.
the dose, I could overdose them.
Okay.
Yeah.
Okay. If they miss more than 1 dose, you need to call the doctor because now we may have heart failure issues, right? They may start to be symptomatic at that point.
Okay.
All right.
Got it.
Because these kids are not good feeders, remember heart babies are not good feeders, we may increase the calories per ounce and we can use either HMF, which we've talked about before, or MCT oil, which we talked about before, right?
Yes.
Feedings need to be less than 30 minutes because what happens if their feedings are too long? What are they doing?
They get tired more easily.
Yeah, and they're going to burn more calories trying to feed than they are actually taking in.
Mhm.
So you will have speech therapy that comes up and you'll have instructions on usually they put it on the baby's crib. It'll say something like PO feed for 10 minutes and then gavage feed the remainder. And that would be through an NG tube. Okay. So you may get an order that says like, all right, this baby needs Enfamil 60 cc's every 3 hours. PO feed for 10 minutes and gavage the rest. So you went to go PO feed this baby. Okay. They took 20 cc's by mouth, right? So now you will gavage 40 cc's because that's the remainder of that feed. Does that make sense?
Okay.
All right. Watch for cyanosis and edema. Now, cyanosis is not common with heart failure, right? But if their lungs start to fill with fluid enough, they might get cyanotic.
Yes.
Okay. If they have new onset edema or the edema is worsening, that does need to be reported because what's happening in your patient?
They're getting fluid.
Yeah, the heart failure is worsening if the edema is worsening, right?
Yeah.
And then you're going to sit them upright just like we do all of our heart failure patients, but especially during feeds because remember, your heart babies cannot feed when they're lying down.
Yes.
Okay. Do we understand heart failure?
Yes.
All right. Now we're going to go to the cardiac cath. It is the exact same as adults. Do y'all remember it?
Yes, a little bit.
Kind of. All right, so I'll go over it quickly.
Hold on.
Okay.
Okay, hold on. Let me. Okay. Yeah.
You with me? All right. This
Yes,
is exactly the same as adults. Nothing is different. So we're going to go through the femoral artery.
Femoral artery.
Right?
Yeah.
To
the heart.
Before the procedure, yeah, and they're going to go up into the heart. Okay. Before the procedure, if you're the pre-op nurse, you're going to do a full history, physical exam, start an IV because they're going to put in contrast. Your most important first thing you do is ask about allergies to shellfish and iodine because you are going to put contrast through that catheter. Okay.
Yes.
This is also very testable and very important. Remember, I don't know if y'all remember this from adult 2, but you need to assess for a groin rash if this baby has a diaper rash. Because if they've got a rash right here and then I stick a catheter in, I'm pushing that yeast or bacteria right into their
heart.
Into the heart.
Okay, so we don't want to do that. Okay, so you need to report that if they've got a diaper rash, and then the physician can go in like through the radial artery or somewhere else. Okay. All right, assess peripheral pulses and mark them with an X. Do y'all remember this?
Yes, because
because you're going to need to document the strength because post-op care, one of the biggest things you do is monitor pulses to make sure they didn't jack up the femoral artery and then they lose this leg. Okay. NPO for 6 to 8 hours for food, 4 hours for clear liquids. Make sure the consent form is signed, but please, as I've always told you, watch how this is worded. If it says you need to go get a consent form signed, no, I do not. That is not my job to give you the risk versus benefits, right? That's a doctor's job. If it says you need to make sure a signed consent form is in the chart, yes, I can do that. Okay. You're going to discuss post-op calf care, which I'm about to cover with you. Make sure they understand that before the procedure because they need to know what their kid's going to look like when it comes out of the procedure. They just do a little bit of sedation. They're not fully under. They're not intubated or anything like that. They usually just give them like some lorazepam or something like that. And then they're going to put them on an EKG because I need to see what your heart's doing while I'm digging around in it. Yeah? All right.
Yes.
After the procedure, this is testable. Have the child lie flat with the leg extended for 4 to 6 hours. And they usually will put a sandbag right here to put some pressure on that insertion site. Because do you want a femoral artery bleed?
No.
Me neither. And then you're going to monitor the pulses below where they went in. Okay. And the other side, of course, because you need to compare. but you're going to monitor those every 15 minutes and the 5 Ps. What happens if you see one of the 5 Ps or 6 Ps, whatever? What happens
you
if you
contact the doctor right away?
Right, because they may lose that
You
leg.
don't warm up their leg.
That's right. I forgot about that. Okay. If you pull back the sandbag and that femoral artery starts going pss, 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 and squirting, you are going to apply pressure where?
4 or 3 up top?
1 inch above the insertion
1
site. Because if you just put your finger on the site, it's going to bleed all around your fingers. You want to put it above the site to clamp off the artery.
Yes.
Okay.
Okay. And then you're going to be like, help, help, and leave your hands there. Okay.
Mm-hmm.
Okay.
If the pulse is slightly, watch your adjective, slightly, or I guess that's an adverb, decreased on the affected side within 1 hour of the procedure, that may be okay. So if they tell you, hey, you're assessing pulses, it's been 15 minutes post-procedure, this side is a +1, this side is a +2, that's okay. But if they say this side is absent, not okay. Or if they say it's been 3 hours since cardiac cath, and this one is at +1 and this one's a +2, no, I don't like that. Okay.
Do you want them both the same?
Decreased blood flow. Yeah, after, see, if it's decreased within 1 hour, that's okay. But anything over 1 hour, they should be the same.
Okay. Okay.
All right. Do you remember these concepts? We got this?
Yes.
All right. Let's go to Kawasaki's disease.
Oh, I struggle with that one.
Okay. This Kawasaki is the one that the protein, or they look like the bellies, right?
No, I think you're thinking of nephrotic syndrome.
Okay, never mind.
Yeah. Kawasaki's disease looks very similar to strep throat, and everything turns
red.
Kawasaki's, everything turns
red.
This is a post-infection vasculitis. What does post mean?
After
an infection, they get, what's vasculitis?
Their vessels get inflamed.
All right, and where do you have vessels?
Everywhere in your body.
Exactly.
Yeah.
So everything turns
red.
Right. And it presents just like strep throat, so it gets misdiagnosed as strep throat a lot. Because look, sore red throat, red strawberry tongue, red rash on the body, high fever, irritable. Doesn't that sound just like strep?
Yes.
All right. But on top of that, they also get red eyes, conjunctivitis, red cracked lips, because they do not feel like eating. Their throat hurts like all holy hell. They get very dehydrated. Okay. They get a very red rash on the palms and the soles. This right here, 1.5 centimeters, is highly testable. They get lymphadenopathy. What is lymphadenopathy?
The lymph nodes.
Very big and swollen, and they have at least one that is over 1.5 centimeters.
Anywhere in their body could be?
Yeah. Okay.
Okay.
So it looks like strep, and it often gets misdiagnosed as strep. So a kid will come in and they're like, oh, my throat hurts so bad, and I've got this red strawberry tongue, and I've got high fever. So they swab for strep. The strep is negative. Doctor sends them home and says you have a viral sore throat. 2 days later, they come in. Mom's like, oh my God, his fever is still super high. It's like 103, and he's not eating or drinking anything. And they're like, oh, maybe the strep was, didn't read it correctly. We'll just treat him for strep. So they give him some amoxicillin. Does that help?
No,
because it's a vasculitis, and the kid keeps getting worse and worse. Okay. Now, why is this in the cardiac module? Because this is a vasculitis. It can cause inflammation and irritation inside the coronary artery. So your body will say,
something is wrong.
And you'll develop a massive coronary artery aneurysm. Now, what's your risk with an aneurysm?
No pooping, no coughing.
Your biggest risk is it'll pop. And then what happens when your coronary artery is just bleeding into your chest?
Oh, that's bad.
This is bad. This is bad. All right. So how do we fix a vasculitis? We're going to give them
inflammation.
Listen to me.
Oh.
This is the only time you can give children aspirin.
Oh, yes.
Okay.
Okay. Because this is the only, because it's aspirin, right? And we know, that's a big no-no under 18, because why?
It gives them the toxic something. Isn't it toxic?
It's a syndrome. What's it called? When you give kids under 18 aspirin.
Vascular. No.
Starts with an R.
Rheumatic fever? No.
Ma'am, no.
No, it's Reyes syndrome.
That's right.
Rye syndrome. Rye.
So because this is the only time you can give aspirin, they often will test you on the treatment for Kawasaki's. They're going to get aspirin to decrease the inflammation in the vessels, and they're going to give IVIG for 5 days. So immunoglobulin. We can give them antipyretics for the fever, of course. Okay. Now, these kids come in very dehydrated because they do not feel like eating anything. They are red and inflamed and swollen and angry. So
what did you say IVIG was?
Intravenous immunoglobulin. Remember we talked about it in the immunization module?
Yes, we give it with the Hep B, or I forgot what mom's. Yeah, right?
You can do it with any disease, but in this case, we're just giving them generic IVIG.
Okay.
All right, and then monitor for dehydration. So we usually start them on a lot of IV fluids, and then you need to keep monitoring that echo because this is a huge danger, the coronary artery aneurysm. Okay. You need to keep this kid calm. So you'll often see test questions about an age group and how do you keep them calm. Okay. So for instance, if you've got a toddler, obviously they're going to want to be with mama, and you're going to want to choose age appropriate calm activities like little puzzles or cardboard books, things like that.
Finger puppets.
Okay, that's right. Just nothing that's very exciting. So I wouldn't pick have them play with trucks in the playroom. Nah, bro, that ain't it. Okay. The other thing that is highly testable is a couple weeks after Kawasaki's disease is treated, their hands and feet are going to start peeling. It's just part of the body getting rid of the toxins. It is normal. It is expected. They just need to keep the skin clean and dry, and it'll just kind of run its course. Okay. As their body is getting rid of these toxins, they also might have diarrhea, vomiting, abdominal pain, joint pain after the disease has already been treated. Those are normal side effects, and we just treat them with medication. Okay. Do we understand Kawasaki's? What does it look like?
Strep throat.
Yes.
Turns everything
red.
All right. Last one, I think. Yeah. Is rheumatic fever. Okay. Anytime you see the word rheumatic, what does that mean?
All over the body.
That's right. That's inflammation everywhere. Now, rheumatic fever is because this child had strep that went either untreated or partially treated. Then it goes into the heart valves, and it congregates around the heart valves. And then what goes through your heart valves?
Blood.
Blood. So that blood picks up that bacteria and takes it where?
Everywhere.
Your whole body.
Everywhere. So rheumatic fever, high rate of sepsis. Okay? But it is rheumatic. So all that bacteria is being taken everywhere. So your entire body says,
something is wrong.
And rheumatic fever looks just like rheumatoid arthritis. Because look at these symptoms, sound familiar. Polyarthritis. What is polyarthritis? Poly means
many.
A lot.
Many. Arthritis.
Your
joints.
Joints are inflamed and angry. Fever. Elevated ESR and CRP. What do those tell me?
Inflammation.
Subcutaneous nodules. That's also from RA. Leukocytosis. That's from RA. Myocarditis. RA. Heart murmurs can happen with RA. What's chorea?
What's erythema margin?
I'm going to come back to that one.
Okay.
What's chorea? Anybody know? It's abnormal muscle movements, but they jerk they look like, how do I explain this? Almost like, you seen somebody with really bad tics that just moves constantly?
Yes.
That's what chorea looks like. Their body cannot sit still, and it's jerking and moving and jerking and moving. Okay? And then you've got erythema marginatum. That's this. What does erythema mean?
Red.
And they get this red rash that is specific to rheumatic fever, and it is called erythema marginatum. Do not
That's the red rash on the skin?
Yeah.
Or the,
do not pick, though, this name for Kawasaki's. This does have a red rash, but it is not called this. Erythema marginatum is specific just to rheumatic fever.
Okay.
So we are going to diagnose with an ASO titer. What's an ASO titer?
That they have
antibody.
It stands for anti-streptolysin titer. So anti means
against
strepto.
Strep.
Lysin
To kill?
To kill. So your body tried to kill the strep, but it didn't completely. So your ASO titer will be positive.
Mm.
Now you can do a strep screen and a throat culture, but the strep may have already resolved in the throat and just moved on over to the heart.
Mm-hmm.
This is a test question sometimes, and on NCLEX and things like that. Ask if they have had a recent throat or skin infection. What skin infection is made of strep?
Impetigo.
Impetigo. Okay.
Impetigo.
And then we're going to do an echocardiogram because they may have myocarditis, a heart murmur. They can also get endocarditis, right? Because it's gathering around the valves. Okay. The treatment, this is wild. So it's often on exams. Bicillin. What's bicillin?
Penicillin.
They have to get an IM monthly shot until they're 18 years old.
18 years old. Time.
Or at least 5 years.
Kid? So if they're a baby, they will have it for at least 5 years. Okay, got it.
No, until they're 18. The at least 5 years part would happen if, let's say, we diagnose this kid at age 15, then they have to be on it for at least 5 years. They would be on it till they're 20.
Isn't that going to affect them in so many ways? Because it's an antibiotic.
Yes, it is. But also endocarditis is life-threatening.
That's true.
We can give analgesics for the joint pain, just like we would if it was RA. And they may need seizure medications to control that chorea, that abnormal muscle.
The abnormal movement.
So we just basically knock them out so that they can keep their body still. Now you're going to have to do a lot of talking to the parents about compliance because nobody wants to take their kid in for bicillin once a month for the next, 15 years. Okay.
Yeah.
We're going to do the same as we do for RA, heat and cold for the joint pain. NSAIDs, just like we did for RA. Okay. Make sure they eat because NSAIDs, remember, tear up the stomach. Watch that heart murmur and for signs of sepsis. How do we know this kid is getting septic?
The blood pressure will go up and then it'll go down.
The blood pressure just goes,
the blood pressure. Oh no, is it the heart rate? I thought the blood pressure, when they're first starting to get septic, it'll elevate and then it'll tank.
With sepsis?
Or is it with the sepsis, it'll just tank?
It just
tanks. The temperature was high too, over.
Yeah, they'll have very high fever that they can't get under control, and the blood pressure will go low, the heart rate will go high because they're starting to go into shock, right?
Yeah.
And then we're going to draw a blood culture for absolute, that's definitive, and then a lactate. Remember, we can do more quickly. A lactate or lactic acid level greater than what equals sepsis?
Greater than 4?
That's correct.
Or is it great? Okay.
Nice job. And then they will require prophylactic antibiotics before any procedures lifelong. Because once I piss off those valves one time,
they're pissed off forever.
That's right. Do we understand?
Yes.
All right. Do you understand the difference between Kawasaki's and rheumatic fever?
Yes.
All right. Any questions on anything we have covered?
No.
No.
Cardiac takes a lot of work, so you're going to have to do this module more than once.
No,
yeah. Oh, yeah.
Okay.
I was getting confused.
Because you got to follow everything through and where's the blood going and what symptoms will it produce because of where the blood's going and yada, yada. Got it?
Got it.
All right. Any questions for me?
No. When are we meeting this week?
I think Wednesday, right?
I thought it was Thursday.
Thursday.